So here I am back with my hypertension. Sorry guys, I went on and on day one I think with my hypertension. So this was a hypertension, of course, what else? So this was a young lady, a 19-year-old lady referred for symptomatic hypertension. Doesn't drink alcohol, no drug use, non-smoker, no NSAIDs, no CPL use, nothing really. Mother hypertensive from her mid to late 30s, so nothing significant really there in the history. On examination, so 210, 118, otherwise really nothing, no bruit. Unlike the first case that day I told you I missed the bruit, that was renal artery stenosis. This time I was a bit more careful, a bit more mature, a bit more older. So no bruit, BMI 26, so not severely raised. So obviously we would want to look at the bloods. Sorry, before that, does she fit into the criteria for screening for secondary hypertension? Yes, well done. So let's quickly go through the indication for screening for secondary hypertension. So severe or resistant hypertension, which means on 3 drugs, one of them is thiazide diuretic maximum dose. Malignant hypertension, I don't bother about number. Some say 200 over 120, some say 200 over 100. I say, look, high blood pressure with some sort of end organ damage. So papilledema, retinal hemorrhages, heart failure, unexplained neurologic disturbance or unexplained AKI. So when I say unexplained AKI, it means no blood, no protein in the urine, and yet you got a creatinine of 200. It's not pre-renal, it's not post-renal, doesn't look renal. To call it renal, almost always I would like to see blood or protein in the urine. I know fundoscopy is a dying art, but I would strongly suggest to try to do it. Papilledema, how do you know it's papilledema? The day you don't see anything round is probably the day you are seeing a papilledema because the margins are gone. Acute rise in blood pressure after the age of 55 or new onset blood pressure is highly suggestive of renal artery stenosis. Hypokalemia, metabolic alkalosis in a hypertensive patient. So I went on and on the other day about primary aldosteronism. High aldosterone causes you to lose potassium and hydrogen, and also I showed you that case renal artery stenosis because they have renin-angiotensin aldosterone activated, so they are almost like secondary aldosteronism people. So they might also have hypokalemia and alkalosis, or the incidental finding of adrenal lesion in a hypertensive patient. So if I went out in the community, screened everybody over the age of 60 to 9%, 6 to 9% of these people will have incidental lesion. But if there is a hypertension in the background, I'll probably look for it. Or the young patient. So this patient was 19. And quickly reminding ourselves, the major causes, the big one is primary aldosteronism. So if June Young and Michael Stoas, June Young in Melbourne and Michael Stoas in Queensland, I think between them they have got a registry of more than 15,000 patients with primary aldosteronism. It is much more commoner than you and I like to think. And over the years, as I grew my interest in this, I started to pick up these patients. Most of the time, it's the patient who is on 5 or 6 antihypertensive medication and you're still struggling, or the patient who has been newly diagnosed to have hypertension is not on thiazide, is not on loop, and yet is running a low-ish potassium. And I always say low-ish. I don't say low because their potassium does not go to the 2.5 mark. They run that 3.3, 3.4, even 3.5, 3.6 level. And metabolic-ish, and again I say ish because they don't run a bicarb of 40, 42. They run around that 32, 33, 34 mark. And I think it's because, remember, aldosterone only acts on the collecting duct. When aldosterone is doing its funny things to the collecting duct because there's too much of aldosterone, other parts of the tubules will compensate. So the electrolyte disturbance are not that profound. Renovascular hypertension, we spoke about the other day. Cushing's, pheochromocytoma, much lower down in the list, as in the number of cases of pheochromocytoma that can cause hypertension. But remember, if you miss it and the patient goes on to have anesthesia, your patient might die. Do not forget these drugs, including the nasal decongestants, cyclosporine tacrolimus, erythropoietin. So those of you who have got CKD patients on EPO can give you hypertension. Of course, the diagnosis of exclusion, you rule out other things, and both acute and chronic disease. I mean, between kidney and blood pressure, I think it's chicken and egg. You got high blood pressure, you can get kidney problem. You got kidney problem due to any reason, whether it's lupus or diabetes, that can trigger off your hypertension. So the big ones, I guess, I would like you to remember is primary aldosteronism and renovascular. But again, the other day I mentioned that renovascular hypertension, unless it's going to change your management plan, do not go looking, because at the end most of them would you will get away with just medical management. Rarer causes, hypothyroidism, hyperparathyroidism. To be fair, I've never seen hypothyroidism or hyperparathyroidism presenting with hypertension, which we confidently said was because of these conditions, but it's there in the literature. Coarctation of aorta, PAN, now polyarteritis nodosa, believe me guys, 30% of these people can present with new hypertension. I think PAN is basically a medium vessel vasculitis, so it's almost like getting renal artery stenosis. If your renal arteries are involved, it's pretty much like a renal artery stenosis, it's just that it's PAN causing it, and those things I spoke about the other day, I'm not going to bore you guys with it again. But if someone wants to catch me, I'm happy to talk. So coming back to our patient, so urine dipstick, a little bit of protein, no blood, sodium 135. So we notice a potassium which is low, little bit of mildly raised kidney function, mildly raised creatinine, sorry. Bicarb 28, not quite alkalotic-ish here, it's 30, I would say alkalotic-ish, and she's not pregnant. So what we have here is a young girl presenting with a blood pressure of 200 over something, who is somewhat hypokalemic and nothing else really. So what do you guys want to do now? Okay. So before that we did the usual ECG, borderline LVH, ESR 27. In the meantime we were running around madly like what's going on, hepatitis, HIV, vasculitis, unremarkable. Brain MRI, so there was no Press-like thing, but there was a aneurysm. Had a echo which again showed moderately increased left ventricular wall thickness, which means the hypertension didn't happen yesterday, it's been there for a while. And then a bit more, I'll come back to your point, but before that a bit more detailed clinical examination, because we were curious like what's going on, we don't know. So let's go back again, let's examine the patient carefully. So we saw those things, and initially we had no idea of what we were looking at, but then eventually we figured out. So Google Images helped. Anyone wants to give it a shot?
Yeah, I think probably this is look like a cafe on your spot. A cafe on your spot.
Well done, well done, very well done.
Probably consistent with mucofibromatosis.
Well done, well done.
And you want to dig if this patient has men or not.
Okay, so we'll go back, go forward. So the first one, the diagram A and B are cutaneous neurofibromas. Diagram C is cafe-yellow macules, and D is axillary freckling. I'll come back to this picture in a minute, but let's just quickly remind ourselves of what they are. Cafe-yellow macules are flat, uniformly hyperpigmented macules. So flat, uniformly hyperpigmented during the first year and increase in number. Axillary or inguinal frecklings, these are small freckles, usually around skin folds, so therefore axillary or inguinal, but they can come anywhere. And then neurofibromas are basically benign Schwann cell tumors, can virtually affect any nerve in the body. The subcutaneous ones lie under the skin, can go up to 5 centimeter, and you can move the skin over them. And they continue to develop, and if anyone has a neurofibromatosis, you can see that they're full of it. If you look at them and they're full of these lumps. And plexiform neurofibromas may be superficial or deep form or nodular, and they have a bag of worms feel and may extend. So now let's go back to that picture. So cutaneous neurofibroma, cafe-yellow macules, which are uniformly hyperpigmented and flat and not raised. So more findings based on these findings. By now we were beginning to get our impression of what we are seeing. So we got an ophthalmology referral which supported what we thought it was. So Licht nodules are something you can get in neurofibromatosis. So I'll let you look at that. So 6 or more macules, freckling, 2 or more neurofibroma or any one plexiform neurofibroma, optic pathway glioma. So this patient had 2 Licht nodules. And then there are those bony changes, parents who meet diagnostic criteria for neurofibromatosis 1 or some sort of, the classic genetic mutation. So she clearly had, and it's not that uncommon if you look at it. 1 in 2600 to 1 in 3000. Half are inherited, rest thought to be mutations, and the mean age of death in these persons is actually quite less compared to the normal average. This is a US study, but I think even in Australia they say these people die a decade earlier because of all the complications that they have. So our patients, so if I go back to the criteria, 6 or more cafe au lait macules, freckling, 2 or more neurofibromas, 2 or more Licht nodules. So our patient had 6, the biggest was more than 15 millimeter. She had axillary freckling, she had 4 neurofibromas that we could identify, 2 Licht nodules, but then we had this hypertension with hypokalemia. So in the meantime, we picked up the phone and spoke with our genetics people in Westmead and asked, do you want me to send urgent bloods for genetic tests? Because I don't know what to do. And I remember him saying, this is neurofibromatosis, don't stress. We'll see the patient in the clinic and we'll arrange for follow-up and bloods and everything. But in the meantime, you guys need to sort out the hypertension. So now we know we've got a neurofibromatosis type 1, but where does the hypertension fit in with that patient? So then didn't know, so more reading around it. So vascular complications of neurofibromatosis type 1. Seen in 5 to 20% of people, renal artery stenosis apparently is the commonest. Coarctation of aorta. Lower down in the list, nevertheless there, pheochromocytoma and paraganglionoma. Now, they tend to develop these vascular complications mostly affecting the large and medium vessels, and I think that's why they get that renal artery stenosis-like picture. It's a medium to large size blood vessel. But interestingly, if you remember, the other day I spoke about renal artery, okay, I said that renal artery stenosis comes under the umbrella of renovascular hypertension, where 10 to 15% people have FMD, and the remaining have renal artery stenosis. And renal artery stenosis is a disease of those over the age of 50. It's basically cholesterol blocking up the renal artery, and it's in the first 2 centimeter of origin of renal artery from the aorta. FMD is more of a disease of the younger people, not related to cholesterol, etc. Histologically, these lesions behave like FMD, but radiologically, they behave like renal artery stenosis, in the stenosis being in the first 2 centimeter of the renal artery origin. So take a note of that last sentence. Renal microaneurysms reported from the loss of elastic and medial components. Before I go to my next slide, just remember any sort of, okay, so if I step back, we as renal physicians and general physicians as well, I think almost all physicians, we stress about proteinuria, and when our diabetic patients develops a bit of proteinuria, we say, okay, let's put them on ACE or ARB. We want to combat the proteinuria. But at the early stage, when people begin to develop proteinuria, if you look at their creatinine carefully, their creatinine is actually better than what it would have been previously, because of the size of the creatinine molecule is significantly smaller than albumin. When they're leaking out albumin, they leak out creatinine, so the eGFR looks super awesome, and they feel, oh, we look good. But actually, no. Why am I worried about the albumin leak? Because as albumin comes down the tubules, the tubular cells try to reabsorb albumin to help the body. The tubular cells say, we've never seen albumin being lost, so we must help the body. And they will reclaim the albumin, trying to help the body. But remember, these cells have never been exposed to albumin. Albumin is toxic. So the tubular cells die, so you've got tubulitis. And as they die, they kind of explode into the interstitium. So now you've got tubulointerstitial disease. And we always talk about glomeruli, but remember 99% of what we filter in the glomeruli is reabsorbed in the tubules. So if your tubules are stuffed up, you're in a bad situation. So you want to combat that, but what do you want to do? How can you do that? So the diabetic guy with a bit of proteinuria, we say put them on RAS. Why do we say that? So when diabetes has got some of these funny things deposited in some of the gloms, and some of the gloms are beginning to die off, the other gloms will try to make up for it. How will they make up? They will make up by making a lot of renin. So these people always have a heightened renin-angiotensin aldosterone system in their body. So renin leads to angiotensin, leads to aldosterone. But what does angiotensin do? It's a vasoconstrictor, constricts the blood pressure, constricts the blood vessels, bring up the blood pressure. But in the kidneys, what does it actually do in the kidney? It increases the glomerular pressure. How? In the glomerular, you've got the afferent arteriole going in, doing a few loops and going out as the efferent arteriole. So it constricts the efferent more than it constricts the afferent. So if it constricts the efferent more than the afferent, some of the blood is going to go down into the tubule. Does it make sense? So if I've got a plastic tube with water running through it and does a few loops, and I make a few holes in these loops, and some of the water will go down these holes. But if I constrict the outflow, more water will go down those holes, isn't it? That's what renin-angiotensin-aldosterone, the angiotensin part of renin-angiotensin-aldosterone does. So the healthy tubules or the healthy glomeruli filter more, and they compensate for the dead tubules and the dead glomeruli, if that makes sense. But as they do that, more protein goes down, and we want to stop the proteinuria. So what do? We just inhibit that process. We decrease the glomerular pressure by inhibiting the renin-angiotensin-aldosterone mechanism, specifically here the angiotensin part of it. So they make less urine and less protein goes down. And hopefully you'll see why I mentioned this. So going on. So now our patient, so you wanted a renin-angiotensin-aldosterone ratio. So the aldosterone is high, but hang on, the renin is super high. So yesterday we said that to diagnose primary aldosteronism, it's not the aldosterone level that you want to show. You want to show me a super low renin level, and therefore the aldosterone renin ratio is high. FeO is negative. What next? So I got a super high renin.
What about the hypoparathyroidism?
I don't think we looked for it. Her calcium was normal. I can't remember. But in context with this high renin, what would you like to do? What can cause the high renin? Good. So because we said that, so when you see a high renin, the first thing you think is it renal artery stenosis, renovascular hypertension? So why do you get hypertensive in renal artery stenosis? Because there's less blood going to your kidney, and your kidney says, less blood coming in, less pressure, I need to do more stuff, makes more renin. And it's the renin-angiotensin-aldosterone activation that leads to hypertension. So we also showed that neurofibromatosis type 1 can be associated with renal artery stenosis. So she had a CT angiogram which confidently ruled out a renal artery stenosis, but I don't know whether you guys can, yeah, you can. So what it showed was multiple tiny foci in keeping with microaneurysm. So I went on and sat with the head of the radiology department in our hospital, and we had a detailed look at it. So there were multiple microaneurysms, and this section has got only a few, but there were a few more. And there's this foci of reduced enhancement in both kidneys, if you see in the next. So what's happening here is you got this aneurysms, and around that you got this dying infarcted renal tissue.
Do you want to explore here polyarthritis symptoms?
Yeah, so that we had the discussion, is this FMD, is this PAN? So she was not behaving, good point. So what Radley is saying that PAN can also lead you to this microaneurysm, although there is classically aneurysm stenosis, but she was not behaving like a vasculitis. Her ESR was 27. There was no story of, with PAN you would expect bruising, you would expect some sort of weight loss, ESR generally to be more than 50, and none of them, and PAN, I think 80% of them have skin changes, about 70% of them have a bit of neuropathy. There's nothing there. It was not fitting in with FMD as well, because their theory was the FMD lesion starts about 2 to 2.5 centimeter after the origin of renal artery from the aorta, but this was more of inside the kidney. So there was these aneurysms and there was dying tissue around it. So segmental vascular stenosis adjacent to the area of microaneurysm. So our theory was there was intra-aneurysm thrombosis, and so not enough blood was flowing, and therefore the foci of kidney tissues was dying off, because it correlated well. Where we had the aneurysm, around those areas we had the dying kidney tissue. So when some parts of the kidney are dying off because of this, the other good part of the kidney would compensate by making more renin. And so we think this is what caused the high renin in this patient. So this was all a theoretical discussion. I don't have any objective evidence to support what I'm saying. And I think we were the first people to come up with this hypothesis. We looked at literature, no one had said that before it. But I can only think of this, because that's exactly what happens in people with kidney disease due to whatever, diabetes, lupus, glomerulonephritis, whatever you want to say. Because all of them end up being proteinuric because of the activated renin-angiotensin aldosterone, specifically the angiotensin part of it. So that will also explain the hypokalemia, because the renin is so high and the aldosterone is, you realize it is higher than normal, and that aldosterone was kicking potassium out of her system.
So this is by definition secondary hyperaldosteronism.
Yes, hyperdynamic hyperaldosteronism. So yeah, but this is, I mean, no one has described this before, so I don't know what to call it. So selective. Then there was some talk about should we go in and do something to those aneurysms, but then because intervention therapy was technically challenging because they were deep inside the kidney, so there was nothing we could do. So I've got around heaps and heaps of medications, including things like spironolactone, which will antagonize the aldosterone, perindopril, which will break her renin-angiotensin-aldosterone axis. So the hypokalemia resolved once we got on control of on top of her blood pressure and spironolactone. So she's taking her medications regularly now, a lifestyle modification. I don't know what the long-term prognosis for this girl is. She's 21, I think. She's on 4 medications. What do we do from here? I don't know, honestly. Blood pressure is controlled now, but eventually which way?
From doing renal biopsy here.
Because I had my diagnosis, I don't know, I mean the creatinine was okay, it was not going to support anything, and I can see what I'm seeing here. And she's full of microaneurysm. I'll be very nervous to put a needle into this girl. She can bleed from those aneurysms. Yeah. So at the end it was, look, it didn't, I mean, treatment-wise, it really doesn't matter how, like us thinking of this hypothesis and coming up with the diagnosis, etc., doesn't matter. But it was a challenging case for us, as in it does have prognosis in regards to her getting married and having children, etc., with the early diagnosis of neurofibromatosis type 1. So 24th December, Santa has to hurry. I'm always mortally terrified of dialysis nurses. There's no one here, so I can get away with it. I don't care what time it is, 4 hours is 4 hours. But I love them, say they look after our patients very well. So thank you, people.